Thanks. I will really take off from Sheraji earlier talking about the fact of us discussing policy not only in terms of 3% and 97%, but at the substantive content. And I think Darshanji has already given us one base for that. What I will be doing is really giving a health systems perspective, because that's the view with which I come into this area, on the role of AYUSH and local health traditions. The current buzzword for health planning is universal access to healthcare. We had primary healthcare earlier that also had a similar approach, but this is the current slogan with which health planning is being done. So what I'm talking about is role of AYUSH and LHD for universal access to healthcare, a health systems perspective. And the issues move exactly from what they were saying. What I'm looking at is really that planning for health has not, from the independence period onwards, where Bhore Committee started us off, not looked critically at medical technologies at all. And it's understandable at that point of time, where we were at a point where antibiotics had just been discovered, all the anti-malaria activities had just started, and so on. So there was a great euphoria and excitement about new medical technologies, and therefore no questioning at that point of time. But today we cannot continue that at all, with the the negative consequences that we've seen of all of that. So that is an issue which takes on, and yet we find that even today the planning is not looking at technological content at all. So I'll take that on as one of the issues. Two, that AYUSH and LHD by the planners is not being looked at for as a technology or as a knowledge system at all. It's entirely for providing doctors where MBBS doctors are not ready to go. And that was something which came across, so I'll, and then the consequences of what that has meant to the way even the planning and the programs that have been taken up. The NRHM that was referred to, which did take it on fairly seriously in 2005-06, and what came out of that. And why the nature of planning that one is seeing, and then the consequences of the present environment, and therefore the way forward for people who are taking on this as a serious issue. So in terms of the planning process, what one sees at the time of independence, when we start our health system planning, is clearly saying that modern medicine is what we are developing. That's clearly the superior science and knowledge. And even the other committees, such as the Chopra Committee and UDUPA, after that, when they talk of integration, it's still that, it is the forms of validation of modern science, it is the integration within the framework of modern medicine that the integration is to happen. And the supremacy, therefore, is clearly stated at that point of time. Subsequently, we've had several committees and 5-year plans which have all reiterated the importance of the systems, of the indigenous systems, and their need for their improved practice, making them available to the masses, and so on. And with all of that, there has been a large infrastructure generated within the public system of dispensaries, hospitals, research councils, national institutes of each of these systems, and so on. And yet, what we've just said, all of that only with 3% of the entire budget, and therefore we have an official pluralism which many countries do not have across the world, and that's extremely important. And extremely important that we have 8 officially recognized, and no other country in the world has that. And therefore that's a unique opportunity that we have, and that strength that we have. Yet it's been a very undemocratic pluralism, and that's really something that we need to keep in mind when we see the way the planning, Chair said that as well, that policymakers are not going to move from that kind of a position, is what she finds even through her research now. And this is when, just to highlight the fact that you have as many dispensaries of AYUSH as you have PHCs in the country, and yet we don't even recognize that. And for the health systems, unfortunately, public health people are completely blind to this part of even the public system. Forget about the systems as an overall. But that it exists at all is something which I find in my public health colleagues just don't know about this. And therefore this blindness. If you go into a district and talk to the CMO about, is there an office of there must be a AYUSH director somewhere, they don't know. They don't even know the existence of such. So that's been the kind of development that has happened. within public systems and beyond. We are producing almost as many AYUSH graduates as we are of modern medicine and so on. So with this very large resource base that the public system has created, that the government has created, we still do not seem to be seeing any echoes of that within the planning processes and the importance being given to it. In the more recent times and the present, we have the National Policy for ISMNH in 2002, which was the first policy document that came out and attempted to place this on a sounder footing. And we had that took on both AYUSH and the local health traditions. That's the codified and the folk that Darshanji spoke of, and but almost nothing in action on the local health traditions. It's almost as if the bureaucracy doesn't know how to address an issue like folk medicine at all. It doesn't know how to take it on into the formal system. But we do have the National Medicinal Plant Board being created. And obviously the purpose of that is developing the commercial dimension of the local health traditions and herbal medicine, because it provides that kind of a demand is globally generated by now for that. The NRHM in 2005-06 did take on mainstreaming of AYUSH and revitalization of local health traditions as an important strategy, and out of that there has been an important intake of AYUSH doctors into the mainstream system, with they being placed in the predominantly allopathic PHCs, community health centers and district hospitals, to the extent of 35%, 52%, almost 76% of district hospitals have an AYUSH doctor and infrastructure and equipment there. But nothing has been done for the local health traditions, again, within this, even though there is strategy and concrete dimensions of that stated. Now, in more recent years, the last 2-3 years, in fact, there's been a high-level expert group on universal health access set up in the Planning Commission. It identifies, its report, has a brief mention of AYUSH. It does talk of it being as an important area, but there's very little substantively in it, and again, no mention at all of local health traditions. The steering group for health on the 12th plan, which is currently being written, identifies AYUSH, and there were 2 steering groups, one for AYUSH and one separately for health. And I believe this time Darshanji will inform us better on that. There were joint meetings as well. So that is a great move forward, as one can see. But yet what one sees in the chapter that finally comes as the draft chapter is the steering group report actually had a very good statement of saying it's a cross-cutting theme, and that AYUSH must inform all dimensions of healthcare, which makes perfect sense. But when you see it in the draft chapter, it is there in many of the sections, the mention of AYUSH and all, but it's 2 separate, completely separate sections. They just don't seem to meet at all, and therefore what integration is seen as really remains very unclear. And steering committee group again did not have LHD in it, but the draft chapter probably has taken it from the steering group on AYUSH and LHD, and does have the notion, for example, of the aerogram. Each block will have one village being developed as an aerogram, which will have herbal gardens and promotion of production of herbal medicines and so on. So that's where we are in the planning process as of now. The way the National Rural Health Mission took it up very clearly was as substitute for the doctors who were not ready to be there in place where they were meant to be posted. But in several states, there is a fairly large percentage of doctors practicing their own systems while they're placed whether in co-located institutions or in standalone AYUSH institutions. Now, the perspective with which all these documents and the programs, as they seem to come through, have several different perspectives with which they're looking at integration. And clearly what is there, number one is ensuring doctors in the public system. It's also for now in the more current frame of giving choice to people and choice to consumers. It is providing choice to patients whether they want allopathy or the other systems, Or sometimes, people have been using it and they want to continue using it, do it because anyway with our doctors not then we're not being able to, give them enough. But it's not with a conviction of value of these systems anywhere at all. The third, which some people seem to come through with, is an architectural correction. They actually recognize the necessity for architectural correction of the health system. When you're saying 3% and 97%, that's a clearly imbalanced architectural structure. And correction of that, and bringing together the best that each system has to offer, as Darshanji pointed out to us, and bringing that together in the public system. But how does this last really happen if the planning process is not discussing technology at all or knowledge systems at all? It is only discussing financing of health. It is discussing the financing structures. Should it be insurance structures that will provide? So the structure will be, is it to be a public system structure or a private contracting in structure, and so on. That's the debate. The knowledge debate just does not exist. And therefore, how can we bring this last dimension in? The options that are available, obviously, for knowledge and technology within the system that people are using and that providers are providing is, one, the major high-tech medical interventions that our corporate sector and specialists of modern medicine bring with them. There are on the side, and people are using it in their own frame, low-cost, high-quality. In fact, providers every day are developing their own low-cost mechanisms to provide low-cost care for prevention, for diagnostics, for therapies. But none of that finds any space in formal systems or any promotion. The third is the patches of other systems, and that is what we are really focusing on and discussing today. And I think part of this discussion on knowledge has to be, when do you stop medical intervention? That must be known as much as knowing when to intervene. None of this is there in the notions of planning very definitely, and that is that has colored the way mindsets are being developed, both of the general public and of the providers of all systems. And that's becoming therefore the dominant mindset, whether the questions, we still remain willy-nilly because our development has not reached the extent that it was planned to, and therefore people still have the other systems available to them and they continue. And the fact that there is a large segment which still remains non-commercialized within these systems. That we have the possibility of saying that you have the kind of choice between perspectives which are commodifying, commercial and profit-oriented versus a service orientation of the local health traditions very specifically, and self-care being an important dimension. Similarly, the whole of whether we're looking at plural systems and continuing plurality, or do we want to homogenize? Even when we say integration, do we want to integrate and make one integrated system of all of these, or do we want to keep the diversity and pluralism on and see that as a strength? These are, I think, issues which are open and need to be discussed and worked through. Now, when we talk of taking on technology as an issue for health systems design, clearly what is done by health systems people is look at these 4 or 5 dimensions: efficacy, safety, delivery system requirements. Do you have the delivery systems in place? Cost effectiveness. And finally, people's empowerment, which was a lot of discussion in the 70s and 80s when we talked of primary health care. And it's completely gone out of any health discourse now. People's empowerment is just not part of any discussion. So that's why we read. While this is just to highlight the fact that studies clearly show the level of iatrogenesis, the kind of side effects created and the negative impact created by modern medicine. And this is taking off from US data, which shows that from the estimates are it's the 3rd killer iatrogenesis in the US, second only to cardiovascular disease and cancers, is doctor-created disease. And half of that is attributed to errors and half to inherent to the disease system, it's to the medical system itself. That's one. The second is when we are looking now to social insurance to make this non-affordable system affordable, is in the US, which has the largest insurance systems. The cost of medical care is the #1 cause of bankruptcy, and the study shows that 90% of those affected by this bankruptcy were middle class people who had insurance. So, these are obviously non-answers, and they're clearly non-answers in the 21st century. If President Obama has this problem and he's not able to sort it out, I don't think any of us across the globe should even try to aspire to this kind of a model. Unfortunately, the 12th plan chapter is trying to take us exactly in the US direction.
Yes.
And that, therefore, is a crucial issue which, how do we therefore see taking on AYUSH and LHT forward in that kind of a frame? Therefore, when we get back to looking at what are affordable, sustainable options, then moving from self-care and health and home remedies needs to be the beginning point from what people are doing, and that's clearly a beginning point that all of us do, and that we know that everybody does, is from home remedies and self-care to health workers, traditional, modern, allopathic, multipathy, all of those, to general practitioners of modern medicine and of AYUSH, and then to specialists again of all these 8 systems. So that would mean from home to tertiary care, we have this whole continuum of care, which we need to factor into any planning process. The planning process must take home remedy into its planning. And why does it need to take it into planning? Because one, we've delegitimized a lot of that, and so we need to actively do plan something for relegitimizing it and revitalizing it. I've just taken an example of diabetes type 2 and what we're doing today. It's very obviously something where textbooks tell you it's diet control and exercise that's first line of treatment. But the diabetologists' guidelines across the world that's been given today is these, with a drug is the ideal, and you don't do it without a drug now for any level of diabetes. Herbal remedies are known across the world, are widely used for diabetes, have even their efficacy has also been shown by modern studies of various kinds, but that's just nowhere in the discussion of diabetologists anywhere, in any literature that one tries to look at. And that is where we should come in India very definitely, and take this on in part of our planning process, and providing for these kind of dimensions. Therefore, if one is looking for, I think I'm already overshooting my time, I can see, so I will not make this move of, I've made most of those points. What I was wanting to take you through was a debate that we had in the Medico Friends Circle about exactly these issues. In fact, the Medico Friends Circle was an organization which had started trying to give a concrete alternative view to universal access to healthcare for the country. And it was part of that debate that we wrote out what are the perspectives on delivering health systems and so on and so forth. And as part of that discussion, what some of us had developed was what should be the service delivery structure for universal access if the public system is to provide universal access to healthcare for all, keeping this view of home remedy to tertiary care as the continuum of care. What should it be? And therefore, this is sort of just indicative, and it's more as putting down something concrete on the table so that discussion can move forward. It was saying that keeping the broad structure of a 3-tier system as we have today, sub-center, primary health center, community health center, and district hospital, and then medical colleges, it would require much more inputs at the community level. So sub-centers, if they move to a lower level from 3 to 5,000 population, you bring them even closer home to people and villages, have greater staff within that with 2 ANMs and 2 MPWs who could be multipathy trained, and 2 AYUSH doctors at that level who can then provide the support for local health tradition and for these multipathy, multi-purpose workers to be using the traditional medicine of that local area, and thereby requiring a much larger set of people being there, and a social worker to knit the intersectoral coordination dimension, which is not happening at all on the ground, even though it's there on paper. Bringing in water, sanitation, nutrition, all of that together, and bringing the integration across pathies into, to make people sit together. To do that, you need a whole process and a point person who's actually charged with that task. So the social worker, we hope, can do that, and also see that various segments of the village are getting services. The PHC should again then come down to a closer home to 15 to 20,000 people, have 2 AYUSH doctors and 2 GPs of modern medicine. The 2 being very clearly experience shows you that 1 doctor means the doctor is either never on leave or is not available. You can't have one person on, as a worker and expect them to be there all the time. Similarly, so moving into this community health centers and sub-district hospitals for 50,000 persons with general practitioners and specialists of AYUSH and modern medicine sitting together, and general and district hospitals again with specialists of AYUSH and modern medicine. Now, once we constructed this, we also said we need to cost this, because that is what would be required, to see what the cost effectiveness of this would be versus that. We took the costing exercise that the National Commission, the Macroeconomic Commission on Health had done, and using their costs, we looked at each of this. What this meant was that we were actually bringing all the costs, for example, for diabetes care, let's say, down 2 pegs, because we started from home remedies rather than starting from the PHC and where the doctor was, as the Commission had done. And thereby we were able to bring that, see, with very liberal sort of keeping it on the high end, 20% decrease in cost was absolutely clearly there. And here we're taking only cost to the system, we're not talking of cost to the patient. But obviously there's cost to the patient when they have to travel to the PHC, lose wages and all of that. So taking all that into account, this is again a very rough exercise, but it's just to show the possibilities.
You'll have to...
I'm winding up now, yeah. So I'll skip all of this and come to the last, which is saying therefore what kind of planning are we looking at? We'd have to be very clear that AYUSH and LHT are, I think, there to stay. Globally there is salience and they're going to be there. The point would be, which approach do we use? A top-down institution-centered approach, or a bottom-up institution building with a people-centered approach? I'm not saying no to institutions, but institutions which are people-centered, or institution becomes the center point, which is how the Planning Commission seems to be talking of universal access. In fact, all of them, whether it's the HLEG or the 12th plan document or the NRHM, you look at what institutions we have and how can we improve them further. But how do we revamp, rethink in a present context doesn't seem to be happening. So, and the question for all of us who are sitting around to do promotion of these systems, in the present environment, how do we ensure that they add to commodification and commercialization of health, or do they add to the checking of the medicalization and commercialization and adding value that they have in themselves? This really is the challenge as I see it now, because it's not that nobody is now being able to wish away AYUSH and LHT, but how they are optimized in the way they are to be used would be the challenge before all of us. Thank you.